is a nice framework that Dr. Bress has laid out, but perhaps I can turn to Dr. Cannon, because in the end, it is ultimately the payer that has a lot to do with what gets covered. So in terms of cardiovascular risk reduction, what do you consider clinically effective, and what are you willing to pay for that?
Yeah, and I think we get that question a lot. What is clinically effective? And you know, unfortunately, I don't know that we've ever come up with a great answer to say this is the mark that you need to hit. And so as a result, we look to national guidelines, and I think icosapent ethyl is a great example. Now seeing endorsement by the ADA and others, and seeing some of the research that is out there as to the reductions in events and those types of things, that all feeds into that cost effectiveness that Dr. Best talked about. And so we're looking at those quality adjusted life years, and we're looking at that $50,000 mark, and we're looking at, you know, is it falling between 50,000 and 150,000? But I think more importantly now, and we look at how can we drive down the cost of the product? If it's clinically appropriate, and I would argue, and I think you guys have all done a great job reinforcing the importance of, say, a drug like icosapent ethyl, that now my obligation on my side is to get that product at the lowest possible cost. So how do I make sure I've reduced the cost to the member? How do I make sure I've reduced the cost of the clients that I have? And then we move ahead in making sure that we use artificial intelligence and lots of tools that we have to identify those patients that will most benefit from that treatment. And our goal really anymore is to not say anything's not covered, but help us identify those patients that are going to benefit the most from it. And I think I look at some of the frameworks we've set up with the clinicians in our area, and we have guidelines under which we're going to use those treatments. But then to the point that Dr. Navarre brought up, she may have a young patient that doesn't necessarily fit within the framework or the guidelines that we established. And so we've built pathways and things so that that information can be communicated to us and we can drive that to those patients. So really saying, this is the mark that we're trying to shoot for in clinical effectiveness, and here's a magic percentage reduction that we have to have. I don't think that exists, but really it's a collaboration across many sciences to say, how do we drive to these effective therapies, knowing that long term, the overall costs of healthcare are going to benefit from our more effectively treating our patients.